Hello. We'll move on to our next case. 51-year-old male, diabetic hypertensive, presented to us with NST ACS with a normal LV function. CAG revealed a triple vessel disease. You can see a long segment diffuse lesion in LAD, which was stented with a good result. Uh, Today, the plan, as you can see, there is a distal RCA lesion, bifurcation lesion involving the ostia of PDA and PLV. The bifurcation stenting of RCA is planned along with OCT guidance. Thank you.
Good morning. Can you guys hear us in the lab?
Yeah.
The mic's on? We are on? Hello, panels? Hello, TRICO?
Good morning, Dr. Talk.
Yeah, we can hear you loud and clear.
Excellent. Good morning, everyone. So,
So
do you see the case? Do you see the angio?
yes, we did actually.
Okay. So this JR4, and we go through the distal radial artery. So I think this one is punctured really well. Everyone can see that?
This.
This is 7 French slender. So it's no problem to get it really easy to go in.
Okay.
So
Run the video.
we put a JR4 in the right coronary artery. You can run it. You can see the distal bifurcation lesion, which is the intended treatment for this section. So I'm going to put 2 wire in, one going to the PLV branch, the big one, which is second one down, and the second one are going to PDA. Then we perform the bifurcation technique. So this is what, 1, 2? Yes, this is 1, 2. Okay. So when you see this lesion, I want to ask a panel, what is your treatment strategy for this distal bifurcation?
So, Dr. Tuck, it's Aaron Grantham.
Hi, Aaron.
We see a Medina 111 bifurcation with a relatively small PDA and a large PL system. And so, to me, this would, I try whenever possible to do a single stent crossover strategy.
Oh.
But in this particular case,
This
I
one
agree
go.
with you. I would wire
That's
both.
good.
I would probably do a balloon angioplasty on the PDA. And in an osteal lesion, I like to use cutting balloons. It wasn't mentioned in the first case from this morning, but I think if you're going to treat a bifurcation, treating the side branch with a cutting balloon can give you a little bit of a nicer dilatation and less likely a dissection. But I would cutting balloon the PDA and then stent across from the distal right up until the PL branch. Provisionally stent the PDA.
So let me ask you, Luis Guzman here. Let me ask you, so even if you are considering a single stent technique, you want to predilate or you want to dilate the ostium of the PDA.
When there's 50% or more lesion, I would do that, yeah.
And then what result will you accept after this predilatation to say, okay, I'm going to change technique to a double stent directly rather than a single stent, or you do not use that predilatation as an indication for that?
Yeah, when there's TIMI 3 flow and less than 70% occlusion, then I tend to leave the side branch alone.
That's good.
All right.
So, so you want to routinely dilate the side branch of a more than stenosis. But someone will argue you might create some dissection in a side branch using this strategy. Then it forces you to a 2-stent strategy. What do you think?
I agree. Anytime you balloon anything, you can create a dissection.
Correct.
But that's why I like to use cutting balloons, because you have
OCT first?
not just longitudinal fibers, you have cross-sectional fibers that you need to get
balloon,
dilated, and I think cutting balloons
PLV.
allow a slightly lower
Yep.
risk of an
2O balloon.
uncontrolled dissection.
So, Doc, this is Kintur. I kind of second the opinion of Aaron. We use chocolate balloon, the coronary chocolate balloon, and similarly, it gives a very controlled expansion, very good luminal gain, and the risk of dissection is very, very small with this chocolate balloon. We have seen that in the below the knee disease, and the similar thing we are seeing in the
Yeah.
side branch.
I don't have a lot of experience for chocolate, but we do a lot of angioscope, maybe the similar thing, but I still found that all the cutting balloon strategy very blocky. If you had a calcium or very tight side branch lesion and right angle, maybe a little bit more difficult to go in. That's my
Yeah,
feeling.
definitely a problem at times with the cutting balloon.
Now, so I put 2Y in already, so I like to do an OCT in beginning, but the lesion may be a little bit more tight in the PLV, so I P-dilated with 2O balloon first, then I OCT that. Okay, let's go up slowly. Go to 8.
It's going 6 and 8.
Okay. Done. Okay, good. So you guys think OCT is okay in this case, or you all like iris? Or no imaging guiding?
Image guiding of some kind I would vote for. I don't have a preference myself, but I'll take
Okay.
other comments.
Yeah, me too. So, but I think this case may be okay for OCT.
So why did you choose OCT over IVUS here?
I no preference to, but I think since Dr. Akasaka is here, but he's not here, so I thought that OCT would be very interesting for us to learn a lot
Yeah,
in this course.
We have Dr. Akasaka in the audience, and I'm sure he can help us out. So great idea, yes. We can
Beautiful.
learn from
Yeah, I'm
Professor
looking-
Akasaka today, yes.
I'm looking for him actually here. So hello, Dr. Akasaka. Are you agree OCT here? Yes. You don't think it's too distal?
He's coming over.
He's coming to the mic.
It's coming to the mic.
Oh, okay.
You can join us, Dr. Akasaka.
Doc, how many percentage of your plan or even ahead of coronary intervention you are using imaging?
I'm using a lot. I think over 80% or 90% in my practice. But my hospital does not using a lot. My patient, my practice, I personally using maybe over 80s.
So we've got Dr. Akasaka here with us in the audience, and we can really learn from him. And
Yes.
he's joined us in the podium, so it's going to be great.
Thank
Thank you.
What do you think here, Dr.? Okay. It's okay?
Yeah, it's okay, yes.
Little distal.
Good, little
distal,
more
Li-
distal, right?
Little bit distal should be much
Oh, that's
better.
fine.
Right, okay.
It's okay, right?
Yeah,
The guy, I think, is sitting really well. You ready for me?
Yeah.
Yes? Good, go.
Yes.
yeah, pull back, right.
Okay.
Oh,
That's
very
fine.
good, very good.
I want to see image. Say some radiation.
Yeah. Can you guys hear me?
Yes, yes.
One question, Dr. Akasaka. Do you prefer manual injection or do you prefer an injector to get real sharp images?
Yeah,
Peter
we
Foucault
often
lesion.
use an injector,
Beautiful, right?
yeah, auto injector.
TCFA
But
also.
in this case, just the limited
Yeah, we can
portion,
remove it.
manual injection should be okay. Yes.
Dr. Akasaka?
Yes, I'm here.
Yeah, you can see
Yes, yes.
this is a mixed plaque,
Yes.
and you can see there is a TCFA, right?
Yeah, right.
TCFA, fibrosis, calcium, some amount of fat also,
Yes.
and I can see a couple of micro channels beyond this area.
Yeah.
And this is a pretty unstable plaque with a predominantly fat and some areas of TCFA, right?
Yeah,
Here
some-
also there is TCFA.
Yeah.
in this region.
It might be the
Yeah.
calcium,
This is not calcium, this is fat, right?
right?
Yeah, it
This is a cholesterol.
this looks like fat because the whole area from here to here is surrounded by fat. But as you rightly notice, there is some filling of a little bit of calcium. But
Yeah.
it is very interesting. TCFA otherwise is a friend of fat, from fatty tissue, the macrophages and foam cell, and then thick cap fibroatheroma and thin cap. But TCFA can exist even with calcium sometimes and even with fibrous area sometimes. That, we have some documented quite a few such cases.
Tejas, have you used the side branch imaging
Yeah.
to determine side branch size before stenting and determine whether you would
No,
pre-dilate?
That usually we do only for the
we're
bifurcation left
standing.
main when there are big arteries, not otherwise.
Yeah, I think if we decide to do two-stand technique, I think I need to image the side branch too.
Yeah.
If we do a provisional, usually I don't.
Because after your balloon dilation, the PDA looks okay.
I think so. Let me review the angiogram. I haven't seen it clearly.
Yeah, could you move the
yeah,
cursor on the
bifurcation.
MRA side? We can identify the side branch here, right?
Yeah.
Yes.
Just
So
come,
put a
we can
bifurcation
identify
software.
Can we see a last shot that
Right.
we had?
Rotate the
wire, right?
rotate the
Yeah, comes,
This is
wire
the
comes,
bifurcation,
yes,
correct?
yes, this is the side branch, yes, PDA, right? So the very eccentric plug, right? The plug is just opposite to the branch. Yeah. And
Yeah. But the ostium is still okay. It's not. How bad is the ostium, the PDA ostium? Can we see it from here?
yes, yes.
Fear of-
Yeah, I think from how to speculate the side branch occlusion is the length of the side branch and also the angle of the carina. So this case may have some risk of yes,
Side branch
side
occlusion.
branch
Yes.
Or great
occlusion,
pinching.
right?
Yeah.
So
yeah,
definitely,
yeah,
I
yeah,
agree. Okay. And what is the distal reference, this one, Dr. Patel?
Yeah,
Is
the
it-
distal reference is
What is the diameter here?
MLA is 1.34. Oh no, this is probably misinterpreting
Yeah.
that. So
How big is artery here?
Yeah.
Can we see a OCT?
yeah,
Can we see the OCT?
2.87 is that area
Oh,
where you can go, and that area seems to be reasonable for deployment. Dr. Akasaka, is that right?
Yes, some lipidic portion, but then only less than 1 quadrant. It should be okay. Yes.
And this is some calcium.
Yes.
Some
yes.
calcium.
Yeah.
So diameter is
But
what?
this is a safe area. Actually,
Yeah,
Yes.
this is what?
This is a safe area.
So
for
this is a,
deployment.
yeah,
This
this
is a
not
safe area.
this is
We
not
can go
much-
even distal and see.
that
No.
distal.
I think this is the best area
Okay.
Yeah.
to deploy. This is the best area.
Okay. And what is the diameter here?
The diameter is 2.62. Area is
2.62.
5.43.
Oh, so
you can
2.5.
take 2.5 and go at a high pressure. No
Yes.
problem.
Okay.
And let me see the proximal landing zone.
2.75 is also okay.
Yeah. Probably 3.0 here.
3.0, 2.75
Yeah.
we can take.
The proximal.
Proximal is just a moment.
Yes.
3.3.
That is no.
Three
This is a good area.
3.3.
Proximal is 3.34. So
Wow.
I think 3 can be a good
3.0.
trade-off.
So 3.0 to 3.5 part, right?
Yeah,
3.0
that's right.
distal and 3.5 proximal.
And the 22.2 is the length.
22.
So
Okay.
maybe
One
20.
question.
20.
Yeah.
So now that you've seen such a lot of plaque burden at the origin of the side branch, do you think you would want to change your strategy, and instead of going for a provisional stenting, do you think you want to go for a double stenting from the very beginning?
No, I don't. I still think double stand in a small
Yeah,
artery
yeah,
is not
yeah.
a good idea.
Fazila, I also agree with Tak
Yeah.
because that will, you know, mess up with the result of the main
Well,
artery.
actually, I also agree with you. I just wanted to ask the
Yeah.
question
Yeah.
because, yes, I mean, this is something that our beginners who are starting with complex lesions should also remember, that just seeing a plaque and especially seeing with beautiful images, we don't really need to
Yeah.
change our strategy.
One should develop attitude of selective blindness. You should not see some things, and then you will be happy.
Yeah, okay. So I would decided to do still provisional standing technique. This case, I think most panels agree, right? Provisional.
Tak, with
Yes.
the consideration from the OCT that there is a chance of this side branch occlusion,
Yes,
would you consider prepping that lesion that you have not prepped yet?
yes. Actually, I still against the idea of a prepping lesion beginning because I still afraid I will convert this side branch into a one stent technique to two stent technique. That's what I'm afraid. This case, I think I will using the gel balloon technique, which is maybe a better approach rather than just put a bare wire in. Put a bare wire in, I think there's some high chance of side branch closure, especially when I see this OCT finding. If I put a balloon protecting the side branch, I might inflate it very gentle, a 2 to 4 atmosphere into the side branch with the stent, okay, alongside, do a small kissing on that, and I think we can have a protect the side branch. This side branch, I don't want to lose it, okay? I think this is my bottom line is try to maintain the flow even though the stent deployed using the gel balloon technique.
Actually, the PDA is arising from a very awkward angle,
Yes.
and it will
Can I
be
have the
difficult
two
to
balloon,
recross
the
if
same
it is
balloon?
occluded. So it's a good idea to protect with a gel
And we're
balloon
using a
because-
3O
Yes.
20 stent.
Yeah,
You had that?
So-
Completely agree.
So
daily
Tak,
balloon
that's a
technique,
very important point, and I would really like you to kind of show that gel balloon technique
balloon, right?
step by step,
This is not.
so the younger crowd can definitely understand how to do it.
Okay, so I put the side branch balloon first.
What about the
I mean, the one
option
of
of
this-
kissing it first and then just to stent the PLV alone?
Mm,
Just to kiss before stenting so
Yes.
that the plaque shift will not be much, and then it can be favorably, this plaque can get reorganized and then just to stent the PLV alone.
Say
Is it a
again,
possibility?
you want kissing the
Before.
lesion first?
Yeah,
Right?
just before
I
the-
still against it to do anything crazy about the side branch. I don't think it's a good idea just to do a kissing. I don't.
So Tuck, you didn't hear what size balloon will you use for the gel balloon technique?
Correct.
And where exactly will you position it across the
Correct.
lesion so you can lift the struts
Yeah.
off the bifurcation?
Give me the stand. 3022 is good. 3022.
What size balloon do you use for the side branch protection, Tuck? We can't hear Louise.
Let's go for the side, for the main branch, and then proximal optimization, and then recross later. And there are all these variation on these techniques. And I think this is a good alternative that it will help in those patients that you have a very difficult to reaccess a side branch. This is a very good technique to be able to do that.
Yep. I think this technique is very popular now in China and Japan, I was told, right, Dr. Akasaka? We just discussed about this case before.
It's very popular in Japan now. Yes.
Okay.
Yeah. Only the wire protection. It might be very difficult to select after the closure
Correct.
or pinch. So
Correct.
yeah, it is important to dilate a little bit.
Yes.
It's quite easy to select the side branch. Yes.
What do you think? So balloon, this is balloon, right? Okay, you want to
So one important
Picture.
technical issue when you want to do proximal optimization is that you have to have at least 8 millimeters of stent in the proximal
I think this is good,
branch
right?
in
So
order
let's
to
go
have a balloon that
to
it will
4,
accommodate
and
for
this one go
those
to 12,
8
okay?
millimeters
This balloon
and
is
prevent
4. Okay, just
a plaque
yeah, go to 12,
disruption
up
prior
to
to the
12.
stent.
This one 12.
So
Up more.
here we have at least
this
6
is
to 8
up.
millimeters.
12.
So I deploy the stent at 12, and the balloon just at 4 atmosphere. Just maintain it down. Down. Okay.
So you went down with the stent first and then the balloons, the small balloon second, or you do it at
I-
the same time, or how do you do it normally?
I do it at the same time usually. Okay.
Any particular reason? There is any science behind, or just
No, I don't think any science behind, right? So let's take the stent balloon out first. So we do slowly one by one. So this case, I'm just using 2 different white, different colors, so I don't need to mess up. Sometimes I always mess up which white. So using some different color. This one's a green in the main branch. I hope I remember. Now, this is side branch balloon should come back without difficulty. So a lot of people ask me if the balloon not coming out. I think it should not be a problem. Okay, so we take a picture and we do a part. We need a 358 or 3510 balloon.
Balloon.
358,
10 balloon.
358 or 10, whatever.
8 or 10.
Yeah, I don't know what available, but then we do OCT afterward. So let's do that.
So Talk, can you talk a little bit
picture.
more about the side branch balloon sizing?
Yes.
Is there a challenge in taking this balloon out depending on the length of the stent used in the main branch? And what are you doing to manage those challenges?
This is all right. The side branch sizing I usually use just a smaller balloon. I don't want to oversize, number one. My goal is not to put another stent in side branch. So I avoid oversizing. So it's no perfect result for the side branch, put it this way. I just don't want it occluded, and I don't want your loss of flow. Right?
So Tuck,
So let's get a part 3.5 balloon. Yes.
You routinely dilate the side branch balloon?
No, I don't routinely
I
dilate it.
typically don't.
I typically don't, unless the side band really tight. A lot of plaque there, which by OCT in the beginning. In the beginning, when I see this lesion, I think I want to put small balloon invasion with the stent together. This is not a typical technique.
But since you did dilate
Yes.
that a little bit, should
Yep.
you rewire the side branch now? And then,
No, I don't rewind now.
Because
I do a part now.
You're just
I
gonna-
do a optimization first. If the side bench looks good, then that's it. I take it out. Right? Okay.
So to do the proximal optimization, you will remove your side branch wire, or you will do the proximal optimization with the wire gel?
I will leave it gel. Well, how about the panel? How many people leave the gel, or how many people take it out?
it seems to me like you're really reversing the effect of the side branch balloon by doing this post-dilation, that you're putting the struts back down where they were before. It may be fine, but it's not clear to me what the advantage of the side branch balloon was. And
Okay, let's go.
Normally, personally, I do take the wire out and I do the proximal optimization
60.
without the wire.
Yeah?
Why?
Why?
I think it's the best way for the strut to move towards where you want the strut to go and
Down.
not to have the wire
Do
blocking
I
that.
Can you do a aerial? Yeah, aerial.
Hello.
I want to see a proximal. Yeah, proximal. Yeah.
So, Aaron, have you come across that situation where you inflated the balloon in the side branch?
I think okay, right?
In this balloon
Yeah.
jailing technique, and then there was difficulty taking it out?
no, I haven't had trouble removing the balloon. The only time I do
Right.
inflate the balloon
Okay,
is
go.
if there's no flow in the side branch. Then you inflate the balloon, lift the struts off the side branch, and then rewire the side branch, take the jailed side branch wire out, and then you have to kiss to get the stent deployed properly, get that raised portion of the stent back down,
Take a side branch right out
and
and
then
take a picture.
reopen
and
the
then OCT.
ostium with another balloon.
So I did have a situation where I had used a longer stent in the main branch, and the side branch balloon after deflation would not come out easily,
Yellow crane.
and the guide catheter was driving in, and basically at that point, it becomes a bit stressful that the guide can go too deep and can cause dissection. So it's very important to avoid just pulling it out. And what we did is we used the
So you take the side branch very slowly, avoid the guy jumping in. Many times the wire should not be gelded by the pot. That's what I'm thinking. So let's do an OCT again.
The other point about removing that wire is when you have a prolapsed wire, if you pull that prolapse back and it engages in the stent, it'll get locked in the stent and it'll unravel when you pull it out.
Yeah.
So be sure your prolapse straightens before you pull a side branch
Correct,
wire.
correct. I think this is very, very good point, yes.
And if it doesn't straighten, it's often very easy to get a Corsair microcatheter down and to straighten it with a microcatheter.
Right, right. So
yeah, also if your wires are really stuck in the side branch, not coming out easily, you can put a balloon or microcatheter down into the gel wire and slowly take it out. So first marker, second marker after the stent is good?
Okay, good.
Okay.
Close this one.
So, let me get a guy in a little bit more.
Okay.
Test for me.
Okay.
It's fine or no?
Yes.
Okay, good.
Chalo.
Ready?
Ready.
Ready?
Yes. Fluoro.
Inject. Excellent, excellent. There is a whirling in the proximal part, but that's all right.
Wow, you see that already?
We will check, let it, go through. We'll check the distal dissection. Go distally. Okay, go distally.
Oh, good.
Check the distal area.
Nice. No
Come
dissection,
back,
eh?
come back. No dissection, absolutely.
No
Perfect,
dissection.
well opposed and well expanded in that region. And then this is the area where
This-
you feel the expansion is
Yeah, side
goes
branch.
down to around 80%.
There's
And
a-
again comes up, side branch.
Can I
and
just-
yeah. Can we use a bifurcation software?
Nice, okay.
No,
So the stand well opposed and the pop
well opposed and well expanded.
and the optimization
And
is good.
now we will do a bifurcation. Let us use the bifurcation software. We will show the PDA ostium, which may not be the best, but the angiographically it looks nice. You can see
Here.
rotate a little bit, yes.
now is rotating. Yes, is rotating all the way.
Yeah. Just
Okay, is it right in the corner? Right on the side? No, the other side? The other side? The other side?
Other side.
The other side?
Other
Yeah.
side, other
Go,
side.
go.
Yeah, this one?
This one.
Just rotate it there. Rotate it there. In the opposite direction. That area actually has not come up so well because it's a small branch. I think it's a very small lumen. Dr. Akasaka, what do you have any advice on this?
yeah, please rotate a little bit around there, right? Yes.
Not
So
see it?
Here is a branch, right? 9 o'clock, right? Yeah, here you can identify the branch
Yeah.
in the bottom, right?
Yeah,
Yeah.
yeah,
Yeah.
The bottom one?
So
yeah.
some strut on the side branch.
Oh, yes.
Okay. Yeah. Right. Yes.
So I think the result is acceptable. It is actually very good for the problem. Yeah, and
But the OCT just not
Yeah.
able to see clearly.
this
Okay.
bifurcation software actually shows something very great when the branches, the lumen of the branches are big.
Vishal.
Anyways, I am going to
Okay,
the
I'll
other
take the
lab.
Y out. Any question from the panel, anything? Yeah.
Yeah.
Maybe do some aerial
LAO.
cranial,
Beta LAO.
aerial cranial, aerial cranial. Yeah, okay, good. Ready? Okay, I think okay, right?
Looks good.
Yeah, the PDA is still there, the stand at pose, and I think
Looks great.
I think, thank you, all right?
Beautifully done. Thank you so much for showing us a beautifully done case. Thank you.
Thank you. Yes, good.